Hey, friends. Welcome back to another episode of the ASAP Pathway Podcast. I'm your host today, Dr. Stacy, and I am honored to have two rock stars that are out there creating just such amazing educational courses, extremely comprehensive, much needed. Doctors Michael Gunson and Rebecca Bockow, welcome.
Thank you. Good to be here.
I'm honored that you're here. I know you're both extremely busy, and for you to take the time is just means a lot. And I just really appreciate you both being here. I wanted to introduce, this is a very abbreviated, when you look at their bios and accomplishments and research and publications, um, it's exhaustive. It's amazing. They're very accomplished. So I'll just do an abbreviated introduction of you both. Dr. Gunson is an associate professor at Boston University School of Dentistry, a resident faculty at Spear Education, and a member of many dental professional groups. He enjoys teaching and lecturing throughout the world and publishing research on orthodontic surgery, facial function, and dental and facial aesthetics, obstructive sleep apnea, and the treatment of TMJ arthritis and condylar resorption. Dr. Bockow is a dual-trained orthodontist and periodontist. She received her BS in biology with honors at Haverford College and completed her DDS training at the University of Washington Dental School. She completed a highly selective dual specialty program combining orthodontics and periodontics at the University of Pennsylvania while also earning a master's in oral biology. You're such a slacker, Rebecca. She is also a resident faculty at Spear Education. Dr. Bockow lectures nationally and contributes to multiple professional journals as an author and editor. And I love to throw in, she's also an ASAP Pathway member, and we appreciate her very much. What I really wanted to highlight today, just have a real just conversation about the why behind your educational platform, what drove you to this, how you met. But first, I wanted to go into the course. It's called Healthy Growth, Healthy Faces. It is September 26th through the 28th of this year, 2024. I'm going to have a link for people to learn more about this course and how to register in the podcast. It is in Kirkland, Washington. And I wanted, if you guys could go into what is this course about? It's very comprehensive. Anyone that attends it is a raving fan. This is much needed in our fast growing field of interceptive orthodontics, collaboration with an oral surgeon that understands airway growth and development and sleep health. Extremely comprehensive. So what I just wanted to ask, just what makes your course, what is the course about first? And then we'll go into what makes the course unique.
Becca?
Okay. So I think what makes our course unique is we start with a healthy face and we identify what is a healthy face, and then we work backwards. And we look at what dysfunctional patterns, what unhealthy patterns happen in a child that lead to unhealthy growth, what compensations is that child making, which contributes to unhealthy growth. And unhealthy growth can be crowding, open bites, underbites, overbites, gummy smiles. And then we look at how do we get that patient back to health. And so for a child, it's growth modification. It's everything from early orthodontic intervention to myofunctional therapy, working collaboratively with other professionals like ENTs, myofunctional therapists, sleep physicians, and then Mike's focus, I'll turn it to you and you can talk about you of course have the non-growing patients.
Yeah, and that's kind of the link. That's why we're together you ask what the topics are. It's healthy growth and healthy faces. And so I intervene when growth is done, but unfortunately when growth is done, almost every situation becomes an interdisciplinary case, right? Because there's
Right.
been the compensations, there's been both myofunctional compensations, speech compensations, airway compensations, dental wear, facial decline. So we can even include the cosmetic surgeons in addressing the facial decline, as well as, you know, what's the cause of all this? Well, the basilar bone positions, right? Which is what that's what my practice is solely, is doing orthodontic surgery to establish the healthy position of the basilar bones so that those other aspects can be, you know, addressed. I mean, and I didn't even talk about postural rehabilitation and things like that as well. So I think the course, because it's comprehensive from growth to compensations to corrections, we get a wide variety of attendees from SLPs, myofunctional therapists, sleep physicians, orthodontists, jaw surgeons, cosmetic surgeons, prosthodontists,
Pediatric dentists.
pediatric dentists. Yeah, I don't want to leave anybody else out, but
Right. Pretty much
honestly, it's
anybody
like,
interested.
and that's what makes the meeting fun too, because we don't accept a whole ton of people to the meetings, because we do like that conversation effect that occurs at a meeting. I can't stand meetings where people can talk and then there's no talk back, because then there's no growth. There's no growth on my end. Like, I learned so much hanging out with these ancillary care folks with treatment of my orthodontic patients. Like, I know much more now, having done this course twice, and this will be our third time. So it's that's the excitement of it, is the interaction, but also we bring something that I don't think is in the minds of those that attend at first, and that's there is a healthy place for the face, a healthy position, and that is where we start. And it's not a question of, well, can we expand, or how much should we expand? Those kind of questions answer themselves when you start from the point of view that each individual patient has a most healthy position, which turns out to be the most aesthetic position actually in the face. So these are the kinds of things that we start with, that basic idea that the face has its functions, and to accomplish them, there is a healthy place for it all.
I love what you said, that there's a healthy place for the face. It's interesting that, over the years, there have been people that have been basically treating to the aesthetics of the face, and they're seeing all these side effects of improved health or sleep, and never really knew maybe why. And they're seeing a beautiful face also equaled. It wasn't just vanity or cosmetics, it also equaled health. And
Yeah.
when you see a face and something's just not exactly right or optimized, you can trail some health issues as well that could be a side effect of that, which is the importance of, and Tracy says this all the time, what is your diagnosis? Because I'm sure you get people that come up to you and, well, what device do you use? And what's your surgical technique? Well,
Yep.
it depends. Like, you have to look at each patient individually, and you have to go backwards and just kind of, you know, kind of go back in time a little bit and see where the hiccup occurred, and where is the deficiency, and
Yeah.
what are we trying to accomplish. Then you can look at your tool belt and say, okay, now what are we going to do? I think in the dental profession, we just want, tell me what to do. How much do I expand? And I'm sure you guys get that a lot in the beginning. And I
Yeah,
just
and
think,
that's
go ahead.
that. I was going to say that's a something we bring up early on in the meeting too, is the banishment of the word normal. And so we start off and say that that is not a word that we will use during our meeting. And in fact, in my practice, I've just X'd it out, because normal means really nothing when it comes to the patient you're treating in front of you, because Normal is an epidemiological statement. It's a statistical analysis of a group of patients that, or subjects that have been brought together to be studied. And you cannot, if on the arrival of a patient, you automatically say that that patient is part of the population that was studied, you've lost. You've already lost the battle, because that may or may not be true.
Well
The
said. Yes.
the definition of normal is what, 66.7% anyway. You're lying underneath this bell curve, and so what? You're going to be wrong a third of the time. If my practice were run that way, I'd be run out of town. So normals help us understand the development of diseases and their associations, but by no means should direct care for the individual patient. So we banish the word normal and we stick with the word healthy.
I love that.
So we talk about unhealthy growth patterns and health, and that really then encompasses, well, it really helps us identify when things are breaking down. So sleep issues is one version of an unhealthy grower, but it also can be unhealthy speech patterns, or compensation secondary to a small lower jaw may lead to TMJ issues, or chronic headaches, breakdown and wear of the teeth, etc.
Well, I also love, we were talking before we started recording, just you mentioned the evaluation of a patient's trajectory of health versus non-health. You said cradle to grave. I sometimes say womb to tomb, but it's so important that we're catching these things. And again, from an ASAP, pathway perspective, we're about early intervention as early as possible, looking for the hiccups, trying to remove obstacles to growth and development so that child can grow into their optimal self. But we can miss windows of opportunity. And thank God we have surgeons like Michael that can come in for the non-grower and help optimize health that way. What are some of the earliest, obviously we can look at birth, lack of nasal breathing, but what are some of the youngest patients that you are teaching to be interceptive with in the course?
We even talk about breastfeeding. So we really talk about early habits and things that happen early on that contribute to healthy growth patterns. So looking at food choices, looking at breathing methods, and so intervention can be a lot of things. Intervention can be helping a child get to the allergist, or taking out adenoids and tonsils early if that's what needs to happen. If there's a tongue tie or some sort of functional component to this unhealthy growth. So really looking comprehensively at these early patients, early intervention.
So when you have in the meetings, participants are leaving, going home with actionable plans on really evaluating and seeing, because it's really important. If you don't understand what a hiccup looks like, if you don't know what poor growth and development looks like, because unfortunately, a lot of the common faces, whether it even be in, celebrities or what we see every day in our practices, commonly is poor growth and development these days. So people don't, they see it over and over, and they're desensitized, and they don't understand what is a red flag in a child or in an adult. And so you go over that, actionable plans to go home.
For sure. Well, and I think, and Tracy says this very beautifully, but that these kids don't grow out of it, whatever it is.
Oh,
these
don't
problems
even get me started.
they don't get better. And so so we focus a lot on growth and development. We break up the course into different skeletal patterns, which is plus minus as educators because there's so much crossover, but trying to at least make it so that it's digestible for the teaching purposes. But so we look at underbites and overbites and open bites and long face, and we have a segment on speech, a segment on TMJ breakdown. We look at lips. We have a segment on sleep. We have a segment on adenoids and tonsils. And we have quite a bit of time devoted to expansion, including MARPEs. But like you said, I have people that ask me, well, is this a MARPE course? No, you will learn about how and when to use a MARPE, and I'll even show a lot of failures and what we do differently today. But that's one tool of how to, I think the real take home is, and I think the power of education right now is being able to understand, once again, what's a healthy face, and to be able to identify what are unhealthy patterns. How do you make a diagnosis, and then make your treatment plan based on that diagnosis?
That is so well said. We have a lot of, it's kind of, I say this almost every episode because it's so true. It's really like the Wild West out there right now, and it's an exciting time. So on one hand, all the talk is a great thing for everyone because it's getting everyone excited and interested. If you looked back 10 years ago, this was not a topic. It was a very rare topic. Now it's definitely there's more rumblings about airway health, early interception. You're hearing more about it even in the orthodontic community, which was just not happening years ago. So, but to have a course where you're pulling it all together and helping attendees walk away with actionable plans on where to even start. There is no way anyone's going to learn everything in one weekend. You're not going to walk away saying, I just know how to do it all. But it is a wonderful, comprehensive starting point, and a place to pull everything together, because it's a lot of it's just not happening. And I think that is, unfortunately, we've had some courses with well-intention, I think, over the years, put airway and orthodontics and early interception on the map, but have left so many different collaborative pieces out that, unfortunately, it may have given this movement maybe a bad name. And I'm just so happy to see you've got oral surgeons, ENTs, orthodontists, pediatric dentists, sleep physicians, SLPs, OMTs, finally coming together and talking. So speaking of collaboration, how on earth did you two even meet?
Good question. I was thinking back to that, and as Becca was describing what we do at the course, and while again, it's not a MARPE course, it's not even a course for tools. We decided early on that what mattered most were patterns and pattern recognition. And so, I think this goes back to when we met, because I think that's what we were initially talking about when we sat down in that auditorium. But there's a quote that's one of my favorite people on the planet was Gregory Bateson, who's an anthropologist, and in describing his philosophies, his daughter said, the pathology is not in the thing, it's in the relationship between the things. And so what we get stuck on is looking at things, and we think that the manifestation of their, like tooth wear, for example, the pathology is not the wear on the tooth, the pathology is it's the relationship that caused those teeth to wear. And when you start thinking that way, you start finding other causes. And And so I
Those that
watched.
didn't see what Rebecca just did, it was a mic
Mic
drop.
drop.
It
Oh,
was mic drop. She
is
just
that what
did,
that was? I don't
yeah,
know.
she did a mic drop for your comment on that. Yes. Go ahead.
So no, and that's what happened is I saw Becca lecturing at I think it was a Spear faculty meeting. I don't know. I don't remember, but it was Spear and I was in the audience and listening to you speak. I was like, okay, well, that's it. I have to talk to her because her presentation was all about patterns of growth in children and interventions that would correct those pattern related problems. And so I always have a laundry list of questions in the back of my brain to ask professionals that are not, in my realm. And so I asked her a bunch of questions, and a lot of her answers were already well thought out, which says a lot about her as well. So that was the beginning. And then I think Spear brought us together from a teaching standpoint when we taught with Frank and Greg and Jim Janikiewski on interdisciplinary care when we were back on campus before COVID. And, that's kind of Frank's approach to things, which is great. I mean, fantastic. He taught us so much. He taught us to get outside the box and start with the upper incisor instead of just trying to fit bites together. So that's a good start. But then Beck and I think, both felt like we had a better chance to speak of patterns and in the face as it is. And so we hit it off. I think our working relationship happened after, actually, sharing patients and referrals and things. I think we were joined more intellectually even before that.
So you guys were referring patients to each other as well prior to putting together hey, we need to take what we're doing and educate others how they can do what we're doing as well, which is huge. And this is how we talked about this earlier, it's not easy putting together coursework. It's not easy putting together, an educational platform, or it's a lot of blood, sweat, and tears and time from your family and your teammates, your team members at your practice are like, we need you in this room and you're in your office working on curriculum. So it's a passion project, and it's bigger than all of us. And this is a much needed, we just make such a difference. I think it's so exciting in dentistry right now to be a dental healthcare provider. I really feel the next 5 to 10 years, the collaboration between medicine and dentistry is going to explode. Because it has to, because we are the answer for so many things that medicine just cannot do. And we really need each other. The collaboration is super important. Do you teach? Because it sounds very, obviously you're talking very multidisciplinary in your course. Do you, because this is the thing, dentistry is not used to working with medicine. Medicine is not taught to work with dentistry. So do you go into how to overcome some of those paradigm shifts in your course, and how attendees can go back and kind of overcome some of those, I guess, maybe fears of stepping out of your norm and reaching out to a sleep physician or an ENT?
I think what we provide is a place for people to start with a knowledge base and a confidence level. This is what we can do on an interdisciplinary team, and empowering the participants to go back to their community and establish their own interdisciplinary team. We also provide a great deal of peer-reviewed literature that they can bring back and say, this is known. This type of intervention has a very positive impact, or this type of intervention has a trend towards a positive impact, whatever it may be. Let's figure out how we can collaborate, and let's talk about what types of patients we can share. And I think no different than when implants were coming on the scene in dentistry, and we had to figure out who are the restorative dentists and the periodontists, and oral surgeons that we want to work with collaboratively, and how do we communicate to the lab techs. And it's a learning curve when you develop your interdisciplinary team. So I think there's a lot of parallels in medicine today, and it's finding people that are open and willing to have those conversations and cross those bridges. And some might not be interested.
Right.
Same in dentistry too, and some are very excited to collaborate.
And we openly, at the meeting, we openly discuss those kinds of things. And Becca makes it a point of making sure that these groups are represented. So, like in our first meeting, you brought your sleep physician, and she was she was given plenty of time to tell us how she felt about us as dental professionals, and that was a great interchange. And then at another meeting, we had Linda D'Onofrio, who's speech pathologist extraordinaire, who just, sat in the back of the room and kept lobbing, bombs that we could address. And it just lent itself to such a great interaction and great discussion. We have a similar kind of lineup for this time, people from, Spain who are coming and who bring a different point of view from a European standpoint, which, it's different in some respects. And I expect that they'll share their opinions as we go along as well. But we've definitely had those discussions, because those are the questions that come up most often, is how do I speak to or work with these different folks. And it's a different group too. I mean, people who seek out, with ASAP, it's like the people that seek you out are people who want more, and that's a different group of people. And so people who show up for CE like this, it's a different group of people, and we're all kind of ravenous for information.
Yes,
and that feeds on itself.
It does. And I think that's something, like you said earlier, and I don't know if we were recording when you said this, and maybe we were, just how much you learn, even having the course yourself, learning from others. And I selfishly, when we started ASAP, we wanted to bring just what we wish we would have had. It can be overwhelming and confusing. I don't know what course to go to. But selfishly, I have learned so much just from members and, even my partners. And when we give courses, and, I always come home just mind blown how much I've learned from a course that we're actually putting together ourselves. So you really have to come to this table humble, because we don't know everything. This is such a fast growing field. He's applauding. Michael's applauding. And anybody that says, I always get hesitant when someone says, I'm the expert, or if someone's like, oh, are you one of the experts in pediatric? I'm like, please take that word expert out of your mouth. Like, we are all learning together, and it's very humbling. And even what I'm doing now isn't what I was doing 2 or 3 years ago, right? I mean, if we're doing the same thing we were doing 2 to 3 years ago, especially in a field that's growing like this, you might want to say, maybe I need to plug myself in and see what's out there, and just make sure that I'm up to date and up on the latest, just because it is growing so fast. And obviously there's the anatomical, which is what we're talking about, and intercepting with the anatomical aspects. But sometimes the anatomical aspects, what we're seeing, could be from something else that wasn't even anatomical necessarily to begin with. Maybe there's so much we're looking at gut health. There's so much with gut health coming out, and diet, and breathing, and the biochemistry, and then how that affects the anatomy that we're seeing. So it tells a story. So I love that you say we teach pattern identification. It is telling a story for that particular patient. And then how do we learn that patient's story and help that patient? What would you say? Because it's a very interesting time right now. Rebecca, with you being an orthodontist and periodontist, but definitely in the orthodontic community, there are some, and I don't know, I'd love to hear from the oral surgery perspective, maxillofacial surgery perspective. I don't know if it's as um, contested or hotly debated like it is in the orthodontic community right now, but for the orthodontists listening that are on the fence, that are, I'm hearing rumblings that what we can do makes a difference. What would you say to them? I mean, that's a loaded question.
Yeah, no, I think I'm just trying to think of where do I start?
Right.
I think at the end of the day, we all want to do great work. We want to be proud of the work we do, and we want to do right by the patient. And I think, for example, if you talk about sleep apnea, if we as the orthodontic community say our intervention, we need to know if we're going to cure sleep apnea. I think that's the wrong goal. We're barking up the wrong tree.
Agreed.
If we say, how can we get to a stable and healthy occlusal endpoint where lips and teeth and joints and soft tissue and hard tissue function in harmony, sleep often ends up being great. But that's not the end goal. We're not treating because of that. And nor do we have the knowledge or the research to say that a single orthodontic intervention will cure a patient. And so I think we need to reframe the conversation. And that's why we put together this course. If we focus on health, then we'll probably end up all speaking the same language. And so it's not a debate about extraction versus non-extraction. It's not a debate about how early is the earliest we can treat a patient. It's about, once again, pattern identification, the proper diagnosis, and then setting up the treatment plan working backwards. And so it's still orthodontics at the end of the day, but it's maybe thinking about it a little bit differently because our why is a little bit different.
I love that.
That's great, Rebecca. That's so well said. And in fact, so Becca and I both just got done writing articles for the Journal of Prosthodontics. There's a sleep apnea edition coming out. So my particular approach was just to show how kind of ridiculous it is to focus solely on the definition of sleep apnea and treatments, because the true definition for sleep apnea is a polysomnograph with an AHI. And if you look at all the studies that have been done associating AHI with craniofacial growth, the studies are terrible.
They are.
It's like, okay, sometimes it's associated, sometimes it's not. In general, the only takeaway from all the research is that if you have a small mandible, yes, that small mandible is somewhat associated with AHI by itself. And then yet we go and, as in our field, we promote craniofacial solutions, right, as the #1 solution. So how well does it show that craniofacial solutions work for fixing AHI only? And the answer is pretty well, but not super great. I mean, all of our results run around 50% reduction in AHIs. Obviously with jaw surgery, a little bit better than that, but even that, the cure rates are less than 40%. So my point in writing that article was to show that it's not that what we're doing is wrong or ineffective. It's that our studies have failed to identify other issues that influence airway and overall health, not just apnea hypopneas. Right. So one of the main issues with people that we miss entirely is this whole idea of, respiratory disturbance where the brain wakes up as a result of resistance or other issues with sleep. And these are difficult to enumerate and the studies that have been done. So if we're going to solely rely on studies that have been done, then you and I are all hamstringed by whatever the author deemed the endpoint. And a lot of times the authors who are deciding endpoints in their studies don't understand the importance of, say, other endpoints or other contributors. So they don't control for different things. And that's, that's always going to be the case. So I'm not criticizing literature. Literature is amazing. But for example, you go to meetings and you listen to Dr. Yoon lecture, and then there's always, the yays, and then there are the naysayers or murmuring after she's done talking. And so I go over to the naysayers and, talk to them, and they're like, well, but she doesn't have any data, I said, well, I think she just presented some data. And then they said, well, but it's not long-term data. And then I said, well, guess who's going to publish the long-term data?
That's right.
It's going to be Audrey. It's not you. Like, you're not publishing long-term data sitting here in the hallway complaining about what she talked about.
That's exactly right.
It's like, if you want to be heard, publish. And this is on me too. Like, I have opinions and things, but I can't necessarily go to bat for them without data and research. So what am I trying to say? I'm just trying to say, if you take a broader view of what health truly is, then you can decipher what's been published.
Agreed.
You can decipher it under the context of what true health really is. And so I think that's where, Becca, I think you're playing it close to the chest. I think you have more to say. But if you don't want to say it, that's fine. But
go ahead. We want to hear what you have to say.
It's part of the course. It's really part of the course too. But Becca's not controversial, and she doesn't like to stir up controversy, but she does want children and her patients to be healthy. So it's a broader view, like she said earlier. I don't mean to speak for you, but
no, well, I think everything you're saying, I agree with Mike and Stacy. And I think too, just being careful as healthcare providers to not overpromise.
100%.
We say this to our surgical cases. You have an AHI of 62. Your bones are in the wrong place. You don't have room for your tongue. We're going to get the parts and the pieces in the right place. We're going to help you function better. When we're done, you will be able to get your lips together. Your teeth will come together. You'll have more space for your tongue. You will sleep better. It will be more healthy. I try not to say beautiful, because who knows what anyone's definition of beauty is.
Right.
But it will be healthy. Your AHI will most likely go down. By how much, I don't know. This is the trend that we see. And then Mike and I have patients that have gone to less than 5 from in the 60s. It's incredible.
That's
because Mike's an amazing
and
surgeon.
Life-changing.
But life-changing for sure. But do we go into the treatment plan promising cure? No, we can't do that. We don't have that. We can't say that.
We can't cure something we don't even fully understand, to be, if we could be just really humble for a minute. Christian Guilleminault, I remember when I first heard him speak at the ADA in 2017, I think it was, when they first had their pediatric airway symposium, the American Dental Association, which is a huge thing for the ADA to say, look, this needs to be on the radar. But he said, I don't even know what sleep apnea is. And like you were saying earlier, is it Mike? I keep calling you Michael. Do you prefer?
Sure. Whatever.
Okay, Mike.
Whatever's easy.
Okay, but we don't even know what sleep apnea is. It's an end-stage disease. We don't even agree on the algorithm in which we're diagnosing it. And then we're saying it's just a moving target right now. So to say, does this treatment cure this condition that we can't even agree on the algorithm and the way of testing for? And really, when I talk to pediatric sleep physicians, they're really looking more and more. The AHI isn't as important, even though it's the standard right now. It's all we have. But AHI is not as important as quality of life. So we need the research. We're starting somewhere. but anything that's been brought to the table to research, it has been, when you look at evidence-based medicine or evidence-based dentistry, it's not just research. You have to look at anecdotally what is happening in our practices too, and looking at patterns. And we used to be really, really good at looking at practice level and multiple practices and what was happening in multiple practices, and that was put into research. And I had a discussion with Mike DeLuke, who's an orthodontist who does a lot of early interceptive orthodontics, seeing amazing quality of life changes in his practice. And he has said, you know, unfortunately, a lot of the research on orthodontics and airway health, it's a later age group. It's 12 to 14 because it's very much university level research. We don't have as much practice level research like we used to, whether that's HIPAA reasons or what, but that's changed. And the average orthodontic school doesn't, or residency doesn't see children at 4, 5, 6, and 7. They're seeing kids ready for braces. And a lot of times that's outside of the growth and development, moldable, or as Mariana says, juicy. They're not as juicy anymore. We can't really intercept with that growth and development. When it comes to oral surgery, what is the temperature with what you're doing and the non-growing patient? Is there much controversy there? I don't think I've heard as much within the oral maxillofacial community, because it's, you know, it's already like, you know, yes, we know that the anatomy matters. They're not growing anymore. Let's make a bigger airway. I don't think there's a big argument there, but do you
No,
find some pushback?
Pushback. We have things that, you know, we throw tomatoes at each other about, but I don't think it's airway so much. I think we all agree, since the 90s, we've all known that this surgery is of benefit, between Powell Riley and White and Hochbahn and all these guys from the 90s that did this. It was obvious that we were having an effect. But even back then, the ENT folks they didn't believe the literature that was sitting in front of them, to tell you the truth. So when I was at UCLA, we were presenting these papers, and they're like, well, that's not true. So, okay.
Okay. What was the basis for that? Like, what was there?
Because I don't know, because they didn't do it. You know, they didn't do orthodontic surgery at the time, and few do now. But so it takes time, and it takes lots of publications. And the pyramid, you know, the pyramid of evidence, the bottom of that pyramid is background information, expert opinion, case-controlled studies, case series and reports, cohort studies, you know, all the stuff that gets bad rep. But in the end, that's the bottom of the pyramid.
Yes,
you
have to build on that.
You don't get to systematic reviews until you've made it through the bottom of the pyramid. So, but as far as, you know, the kinds of things that are debated or up for debate are things like, should we be taking jaws? Okay, well, let's take one. Powell and Riley and also Dr. White early on were doing, it was termed maxillomandibular advancement, and the idea was to come straight forward with the jaws. And they did. But the problem is they weren't really appreciating how the jaws weren't growing correctly. It wasn't a case of anterior posterior position. The logic is that if you're going to make a bigger airway, you're going to push forward, right? But as people like Larry Andrews and my retired partner, Dr. Annette, started studying the face and facial development, then it's like, well, you know what? A huge portion of these patients aren't just growing forward, but they're growing vertically. In which case, doing a straight advancement looks weird, strange, and really doesn't provide a level of health that we would expect. So now all of a sudden it's like, oh, well, maybe we should be shortening the anterior face height. It looks better, but what's the functional component? Well, the functional component is getting lip seal, right? Getting the lips to touch. Well, that's definitely, if you go across the United States now and you ask all the oral surgeons are you treating to lip seal? And the answer is like, what?
What?
So not all of them. I mean, obviously there are many that do, but it's my experience, at least 10 years ago, where that wasn't considered at all. And
Right.
in the analyses, it's not considered. But we knew as far back as rickets and in the late 60s, early 70s, that lip seal was a real problem. And they told us that it was, but for some reason we're like, all right, sure. But no studies, no follow-up. And now, you get books, by Nestor, and you get, oh shoot, you want to go back. It was in the late 1800s that these things were being published in the ENT literature
Yes.
to get lip seal. But again, does it really matter with orthodontics? So yeah, we don't throw tomatoes at each other when we say things like that. If you want real arguments, talk about the joints. But I think there's just a different way of doing things. There was an interesting interaction. I was at a meeting this last weekend with, I think, 6 or 7 oral surgeons, and we were all together being nice, and we left our egos in our hotel room, and we were talking about where to put the jaws. And it was interesting because I heard from 2 of them, they're like, if you can't fix the airway while making the face aesthetic, then the problem is not in the bones. In other words, because people think MMA, and then so it's like, oh, let's blast the jaws forward, right? And it looks unaesthetic. It becomes, monkey face or bulldog face. So I was heartened to hear people say, well, if it requires us to make, simian faces to get airway cures, then maybe we're not treating the problem where the problem really lives. Because wouldn't nature lend itself to an aesthetic outcome? And the answer is yes, because it has to do with making babies, and, agreeing to make babies. And that's based on attractiveness. So yeah, things are changing. I think that was a huge outcome, and at least in my mind, was to hear fellow surgeons talk about an aesthetic outcome from MMA. That's huge.
That is huge. I think it's interesting too, when I will talk to a group that are, hesitant as to whether orthopedics, orthodontics is kind of worthwhile. And when you look at, a CEF or a CBCT sagittal, and you look at this really small, very tiny airway, and again, you can have a small airway with no problems, and you can have a big airway with problems, but definitely collapsibility. The bigger you make it, you have less of a P-crit issue, and it does lend itself to less collapsibility sometimes, but there's a functional component to that as well. But when you look at, a non-growing patient, and then you see the same anatomical problem in a 7-year-old or a 6-year-old, it's like, and they're not sleeping, and they have cognitive deficits, and, sleep fragmentation. It's like, why are we not logically saying, let's optimize their growth and development while you can, and do a non-surgical MMA of sorts, if you will? And it's just, sometimes I just see this glazed look over people's faces, and I'm like, I just don't understand. Sometimes there's just a hesitancy there. And I think sometimes it's fear-based. I think people don't necessarily, sometimes they're in a groove, their practice runs a certain way, and they really don't want to change. They don't, and that's okay. But what I'm hoping is, if you don't want to do the early interceptive, and that's fine, but maybe identify the patterns, learn the patterns, learn that patient's story, and then maybe refer appropriately. Start asking more questions about their sleep, their breathing, executive function, and maybe if you aren't comfortable doing it, that's okay, but refer appropriately to someone that is comfortable doing that, or has no problem seeing maybe a 4, 5, 6, 7-year-old behavior management wise, that maybe it makes them uncomfortable to see someone that young, and that's okay. But just stepping out of your box and having conversations in your community of who is willing to see this kiddo that has circles under their eyes and ADHD and bedwetting and doing poorly in school. And, maybe you should refer to someone that is open to, seeing if they can optimize their health at a younger age. Because, like Tracy says, you know, um, they're not growing out of it, they're growing into it. The malocclusion does not improve itself on its own. It only gets worse. Rebecca's shaking her head.
Yep.
Do you have anything to say about that? Just kind of like even looking at the non-grower phenotypically, like you look at this non-growing Seth, this patient has a very similar phenotype to maybe a child at 7 or 8 who you see where they're headed. They're not growing out of this.
Right. Well, and I'll to the orthodontist listening to, and pediatric, anyone listening, it's not only will they not grow out of it, but the problems get worse and get harder to treat. And so, for example, canines, when that maxilla is narrow, we see crowding, and impacted canines are just another version of a small upper arch. Impacted ectopic blocked out canines. And so if we expand early, we make room for those teeth to come in and to come in into healthy gingiva, into healthy alveolar bone, and it becomes a much easier malocclusion to treat when they are 12, 13, 14. If we wait, we're dealing with impacted canines, we're dealing with root resorption of the lateral incisors, we're dealing with ectopic canines, we don't have healthy gingiva. So airway aside, if we focus on the periodontium, if we focus on the dental component, there's reasons to expand early.
Absolutely.
When indicated.
And this is a perfect example of me and Becca, like why I'm associated with Becca. I'm tied at the hip is because pre-surgically, one of the biggest problems for me to resolve aesthetically in a face is the complete mesialization of the arch, the maxillary arch, right? So I sit through a lecture Becca gives about ectopic crowded out canines, and she's saying that because of that, you get complete mesialization of the arch. And I'm like, what? So yes, this is what it's like, okay, this happens, growth and development. She sees it. I'm living it and trying to deal with it. And that's how, we kind of, whoa, my camera's going bananas. that's how we come together on this issue. And it's like, because it's few and far between that I'm able to actually request of an orthodontist to distalize an arch, but it's desperately what I need to get a great result. And that's one of the cases that, Becca presents is a case where we did that. I mean, we distalized the arch in order to make space so that I could get the aesthetic result that I needed in an airway patient. But this goes way beyond this 50-year-old that we treated together. This goes back to when that kid was a little kid and how that space was managed or not managed
right
for the erupting canines. So, I mean, just to listen to Becca is just like, oh my gosh, this is what I live. I'm on the other end of what she's living day to day and treating these kiddos.
Well, I highly encourage, you guys are a dynamic duo and you are a breath of fresh air and much needed in this arena of comprehensive orthodontics and oral surgery collaboration. So I highly encourage everyone go to our podcast link, check out the registration. Also, we have if you're interested in what's up in ASAP, we have a free newsletter and free forms. I'll have that in the link just so you guys can stay up on what's going on in ASAP. And we promote and support our colleagues doing amazing work, as Mike said earlier, doing God's work and just really getting the message out there and helping kids and helping adults that fell through the cracks, and the medical community doesn't have an answer for them. So we are the answer. And I know you guys have to go, but I have to ask my spontaneous questions at the end before you guys go. All right, here we go. I'm going to ask each of you this: chocolate or vanilla? Go ahead,
Chocolate.
Rebecca. Your chocolate?
Chocolate.
What are you, Mike?
Oh, chocolate, absolutely.
Oh, chocolate all the way. All right.
Well, Stacy doesn't know our T-shirt, maybe.
What is your
No.
t-shirt? What is your
Well,
t-shirt?
you'll have to come to the course to find out about
no,
chocolate cake.
suspense.
Chocolate
Chocolate
cake.
cake.
All right, I have to go check it out. I saw a bunch of t-shirts in your Facebook post. Now I got to go back and look at it. Okay, second question. Coffee or tea? Are you a coffee or a tea person? Or neither?
Mike might have a different preferred drink. I'll say coffee for me. I'll leave
Okay.
that one to Mike.
My
Diet
picture-
Coke.
Diet Coke. Ooh, I'm a Diet Dr. Pepper person. I got to watch it. It's my vice. And what is your favorite thing to do on your day off?
I'll have two, hang out with my family and go for a run.
Mm. Good for you,
Yep.
Mike.
Same. I think it's definitely spend time with my family and be outside no matter where it is, especially here in Santa Barbara.
Oh yeah, I'm looking at your background there. I can see you look
It's time to go outside.
it's time to go outside. It looks just horrible there in Santa Barbara right
Yeah,
now.
it's tough. It's tough to live here.
Well, thank you guys so much. Appreciate your time. We know how valuable it is. And thanks everybody for joining us today. And we'll see you next time.
Thanks.
Thanks
See you
for
soon,
having us.
Becca. Bye.